Hello, Assalamualaikum. This is Group 5 Oncology Journal Club. The members of our group are Siti, me, Nikki, Christina, Nadia, and Shafika. Today we are presenting a review article in 6-part series. I'll start from the first part to introduce about the article. Our article title is Cervical Cancer Prevention in Countries with the Highest HIV Prevalence, a Review of Policy. Insight to this article is that this article touches on the review policies in preventing cervical cancer. First, we have to understand what is a policy review. Simply, it means to review, add goals, strategies, creating an ongoing development on a working particular policies. Now, what does it entail actually? It entails important documents considered in making, suggestions for changes and improvements, and breakdown of issues within the policy document. To introduce the article, first, the severity of cervical cancers, especially in the sub-Saharan Africa, as you can see from this map, sub-Saharan Africa, women living with HIV have greater risk of acquiring cervical cancer. The severity of geographic differences in the frequency of cervical cancer illness reflects the accessibility, coverage, and effectiveness of preventive measures as well as the predominance of risk factors. HIV incidents were highlighted by the authors in this systematic review of a national policies, plans, guidelines, strategy studies based on countries with HIV prevalence above 10%. Alright, moving on to the next part is the methods. A systematic review was applied in this medical literature that used explicit and reproducible methods. A prisma flow diagram was categorized in this article, following eligibility criteria for countries and documents and information sources and searches such as Medline, PubMed, and ICC. Thank you. I will forward this presentation to Christina.
Thank you, Miki. Now let's move on to the data from the article.
From the article data, women with HIV are prone in developing cervical cancer compared to HIV-negative women. Other than that, women with HIV have higher risk in HPV, lower chances in clearing infections, faster progression to cervical cancer, and high recurrence following treatment. There are many effective prevention programs in HIC that helps in reducing the incidence of cervical cancer. However, the cervical cancer screening remains undetermined due to lack of resources, limited number of healthcare staff, and competing in health priorities. World Health Organization (WHO) highlights the need of quality control of screening services nationally and globally, including the collection of data to standardize the progress, performance, and impact signed. Based on the database and registers, the study records obtained from PubMed were 1,746 numbers. Meanwhile, via other methods, there were 44 numbers. And after going through some screening and processes, 11 study reports were excluded due to no information on the cervical cancer prevention. Using Prisma flowchart study selection that have been provided in the article, the number of studies included in the review is 33, with the division of 8 from the International Cancer Control website, 3 from the National Ministry of Health website, and 22 from the expert consultant. Next, I'll pass the slides to the Alira Nadia.
Thank you, Christina. Following an extensive investigation, the researcher reduced it to 9 nations with HIV prevalence of 10% in 2018 out of 49 countries existing in sub-Saharan Africa to analyze their policy documents. The prevalence policies were discussed as below. The first policy examined is the cervical cancer primary prevention policy, which includes HPV vaccination, sex education, condom use, voluntary medical male circumcision, and tobacco control. The researcher discovered that only 77.78% of countries reported to have some part of the HPV vaccine in their policy statement. According to the findings, 4 out of 7 countries have a school-based vaccination policy, so the immunization will be given to girls at school. 3 of the 6 countries said their targeted vaccination population was girls aged 9 to 13, and only Namibia and Malawi include the HPV vaccine criteria of 3-dose vaccination regimen for HIV-positive girls. Next, the secondary prevention includes screening and treatment for cervical pre-cancer lesions. From the table, we can see the various options available for screening method from 9 countries. All of these countries use visual inspection with acetic acid and pap smear, where both of these is considered inexpensive compared to other methods. Lesotho and South Africa are the countries with more options for screening services compared to other countries. This significant differences in screening method availability from these 9 countries contribute to the extremely low uptake of cervical cancer screening in sub-Saharan Africa. As for the treatment of pre-cancer resolution, all 9 countries use cryotherapy, which use extreme cold to freeze and remove abnormal tissue. As we already talked about the treatment for pre-cancer resolution, now move on to the treatment of invasive cervical cancer as tertiary prevention. The treatment services availability was reported in 6 out of 9 countries, which is surgery, radiotherapy, chemotherapy, and the palliative care. As for the monitoring and surveillance mechanism, 3 of the 9 countries are reported to still be using paper-based data. Electronic and digital systems were recommended for collecting data, but certain health facilities in sub-Saharan Africa prefer paper-based because they are reported to be struggling with technology. As for the cost of services to women, only 3 countries reveal their treatment costs according to the researcher. Malawi, a government facility in Lesotho, and a South African school were all mentioned in the policy document as having free HPV vaccination distribution. Free cervical screening services are exclusively available to vulnerable groups in Botswana and the health facility in Malawi, South Africa, Mozambique, and Namibia. Women in Zimbabwe must pay for these services and it is pricey. As for cervical pre-cancer lesions, are treated for free in Malawi, South Africa, and selected Zimbabwe health facilities, and for the vulnerable group in Botswana. That's all for the result. I'll pass it to Siti.
Alright, thank you, Mira. I will gladly take it from here. Well, what you see, my beloved audience, is the appraisal recon and assess for the policies and the recommendation of cervical cancer prevention in all sub-Saharan African countries listed with the highest HIV prevalence. So, allow me to enlighten you to our first discussion topic of the day, which is quite hefty yet very vital, the comparison with WHO guidelines and its current evidence. On to my first findings, I believe based on the HPV vaccination strategy approaches, the most common age group reported are in between 9 to 14 years old, and in addition, it is suggested to be within their national immunization programs. A recent report too in LMICs showed that 5 over 9 countries included in this review have introduced HPV vaccination, partially or nationwide, which corresponds to information extracted from their policy documents. Next, referring to the vaccine dose settings, WHO suggests to continue with 3 doses. However, recent evidence suggests that a 1-dose vaccination schedule for girls in the general population is effective against persistent HPV infection. And as an extra findings, for girls living with HIV, whether the number of doses can be reduced to 2 remains unclear. Other than that, tobacco use reduction is one of WHO's best buys for primary prevention of NCDs, including CC, and all countries align their tobacco control policy with WHO's framework Convention for Tobacco Control, also known as FCTC, recommending price and tax measures to reduce demand for tobacco, bans on advertising and sponsorship, as well as education and public. Now, pointing out to our second topic of discussion, significance to WHO's guideline and current evidence. Firstly, the WHO recommends that women living with HIV are screened with the HPV DNA test rather than VIA or cytology, even though it is commonly available and used in 5 countries. And although HPV vaccination has been shown to be beneficial in reducing, it may not be the best investment unlimited healthcare resources contact, because limited financial resources was highlighted in policy documents in certain countries as a barrier to extension of vaccination services to boys. Following closely, in several SSA countries, the predominance of paper-based monitoring systems limits the collection of comprehensive CC data, including indicators disaggregated by HIV status. Why? Because national CC prevention and control activities are usually dispersed across different bodies or units without centralized data systems, thus making monitoring even more complex and challenging. Then, the WHO also recommends integrating HIV and CC services. This will allow service providers to increase their skills and knowledge, improving care for a high-risk population, and at the same time reducing stigma and improving cost-effective use of resources. Funding for CC prevention is limited, which implies that CC prevention services are not always free, creating a barrier to access. That is all for my part. Now I will pass the next hard discussion sharing to Shah.
So now let's talk about the strength and also the weakness. For the strengths, the analysis was strengthened by the exhaustive search and the data collections achieved, the supplemented online searches with the policy documented, published and also unpublished, and also the direct communications with the country experts. And here we can see that the reported data items and indicators that present the entire cervical cancer preventions and care continuums are only registered indicators disaggregated by the HIV status as seen in the policy documents. For the weakness, it focused more on the global indicators for monitoring progress toward the cervical cancer eliminations in this analysis, which does not account for the indicator defined for the subnational and national monitoring of cervical cancer preventions and also the control programs. And here we can see that the expert responses may only reflect the programs they work for and may not represent the national practices, and some of the information collected through this systematic review process may have changed. In conclusion, the nation in sub-Saharan Africa is mostly making headway toward the developing and implementing policies to control and prevent the cervical cancer. The country in sub-Saharan Africa has a lot of HIV cases, so that the national policies for controlling cervical cancer should focus more on women who have HIV because they need more specific care for it. The most significant action that must be taken is to adapt the cervical cancer preventions and control policies to the current healthcare realities by updating them in accordance to the WHO guidelines. A better actions taken will ensure that the prevention of cervical cancer will bear its fruits and to have much more efficient way of treatment and also management.
Thank you for watching. I hope our presentation just now gave you more insight about the cervical cancer preventions. And if you guys have any comments or any questions, you can just drop it. And then see you. Bye bye.